Thank you. And it's a pleasure to be here, and it's a pleasure that you all had the opportunity to stick around, and hopefully we'll give you a little bit of insight as to where Philips is going to be going in the areas of 3D quantitative imaging, workflow optimized and standardized. And the reason for why we're focused in this area is because of the fact that the body itself is 3D. When we look at images and when we analyze images, we can't just look at the body and think about the body in 2D as we always have done in the past. Especially with newer technologies that are coming out that will help us model this, and you can see some of those technologies on the IntelliSpace Portal version 10 with things like 3D printing. We have to think about how we can better diagnose in 3 dimensions as well. The challenge that's created is the fact that the more you think about 3D, the more data has to be accounted for, and the more we have to think about different workflows. And that's why part of the challenge is to then standardize and optimize our workflow when we think about a broader data set than we normally have. So why is this an issue? Well, if you consider the challenges that radiologists face today is that they face multiple different information systems. This is data that's coming at them from so many different angles, whether it's from the EMR, whether it's from the PACS, whether it's from the RIS, or even our own advanced visualization systems. They also have to take a look at data from multiple different modalities. We can't just look at a single CT, we take a look at how we can compare images between CTs, MRs, multiple different imaging platforms, and try and synthesize that data to get a more holistic view of the patient. At the same time, we have to consider multiple different clinical domains. There could be lots of comorbidities. So the main question is how do we take all that data and put it into a model that makes sense, that makes it easy for our radiologists, for our partners, to be able to make very good diagnosis, quantitative diagnosis for our patients. The more quantitative we can be, the better we can follow up on care, the better we can do reporting, and the more, hopefully with reimbursement, we can get there as well. And the platform that we have at Philips that helps us get there are 2 particular products that we work on. One is the Illumeo with adaptive intelligence, which I'm sure you'll hear more about at the booth behind us. And the other one is, of course, our IntelliSpace Portal, which is our advanced visualization platform, which brings all of our most advanced capabilities into a single platform. And the idea is that what we'd like to do is use these platforms to synthesize data, 3D data, to make it easier for radiologists to very quickly make a diagnosis and workflow decisions. So the way that we can do this, and what are the tools that we have for better confident diagnosis? Number one is we can use contextual relevance. You can have a lot of data, but unless you know how to manage it and where to put it, and what those numbers will mean in the context of the patient care and where they are, it'll be of less importance to you. And the second thing is that we'd like to reduce variability by being able to bring in standard, easy tools to be able to help manage that. And we're going to see how we do that using 2 different applications that we have on the IntelliSpace Portal today. Number one is the comparative brain imaging, or longitudinal and comparative brain imaging application that we have. And the other one, which Dr. Chapiro, my friend, will bring up right after me, is in how we look at 3D diagnosis of cancer using multimodality tumor tracking with the QEasel application. So starting with comparative brain imaging, why is this of such seminal importance? Is because if you take a look at the economic burden of brain disorders, we're going to talk about quantitative, let's get very quantitative. The economic burden of brain disorders is incredibly high. In fact, it's so high that we talk about things like cancer, and cancer as being a very, very large element that we all focus on. But overall, actually, neurological disorders, the US spends more on neurological disorders overall than they do on cancer itself, which lends us to think about how we can provide solutions that will help us quantify that degree of data and give a 3D overview of that data when we look at the brain. To do this, we have an application called MR longitudinal brain imaging. And essentially what this application does is, instead of just looking at 2D images, what it'll do is it'll automatically take images from the MR, line them up against the previous scans that patient has had, and take a look at how we can actually quantify each one of those tumors or each one of those lesions, not only in 2D, but it takes automatic 3D measurements itself. And not only does it do that, but it quantifies all of that and puts it into graphical form that helps us better communicate that information to referring physicians, to neurologists, et cetera. Okay? And that's of tremendous value, especially if you want to take a look at getting not just a diagnostic report, but a very quantitatively diagnostic report. And I can tell you that I've sat in on many, many different neuro sessions when a lot of the neurorads and the rads themselves have kind of looked at differences between lesions and said, well, is this patient progressing or regressing? Are they getting worse? Are they potentially getting better? And a lot of times, those changes in the lesions can actually be very, very small and very, very subtle. So what we have as part of this application is the opportunity to analyze and color code differences in 3D terms so that you can very easily and very quickly see what the differences are in a patient over time. And if we take a look at getting down again to some quantitative metrics, when we started to take a look at what are our radiologists saying about applications like this, in over 20% of the cases, COBE, this application that I've mentioned, helped radiologists detect previously unidentified changes in the brain, which can have severe ramifications for the patient involved. And if we take a look at COBE's impact on follow-on brain scan reading, it's made it easier for physicians to decide faster and offer them much more confidence with a whole robust set of 3D tools that we can offer when we're talking about the most complex, complex organ in the body, which is the brain. So this gives a very high-level overview of some of the tools that we're bringing in with 3D automatic quantitative workflow optimization with those tools that we've seen in the comparative brain application and longitudinal brain imaging application. And what I'd like to do now is hand it over to my colleague, to my friend, Dr. Chapiro, to talk about how we're doing this in cancer management as well. Dr. Chapiro?
Well, thank you so much, Kevin. And it's a pleasure, really, to share the story of our collaboration and co-investigation between an academic institution, a co-creation story between us and Philips. We started 5 years ago with the idea to really improve liver cancer imaging, and we moved it all the way from very, very initial steps towards a product that is now 510(k) approved. And I will also talk about not only about the co-creation story, but also, and most importantly, about the future of liver imaging, and specifically focus on interventional oncology, a new growing field. First of all, the big picture for you, we in interventional oncology envision it. If you look at the system of cancer care in our society, we do have the three traditional columns of cancer care. We do have surgical oncology, medical oncology, and radiation oncology, fields that have been established over the last generations. And we now have a new player in the field. This is interventional oncology, basically minimally invasive, image-guided tumor therapies, mostly in the liver as well as in the kidney, and now increasingly in the lung. And we're moving really rapidly, and this field is growing mostly because of the basic and translational research that we are doing alone with federal money, but also together with our industry partners. And this is actually a key aspect of what I'm going to be talking about. Now, briefly towards the local regional transarterial therapies, we're looking at an approach that is minimally invasive, image-guided, and delivers a highly concentrated chemoembolic agent towards the liver without causing too much damage to the actually healthy liver tissue. And this is something very unique about the liver, and I'll talk about this more, but the necessity to understand why we need a specific dedicated imaging system for liver cancer is the actually dual blood supply of this organ. And if we introduce this ischemic insult, and if we embolize those lesions with local regional therapies, what happens is that we introduce significant changes to the way those tumors look like. And what happens is that after the therapy, we do have our follow-up imaging, and we need to make a decision on whether or not the therapy has failed, or whether or not to retreat this patient because the therapy was incomplete. And for that, we need very specific tools to really assess those lesions for response. So what kind of tools do we have as of now? The conventional science offers very, very basic caliper-based tools that either measure the anatomy of the lesion as a diameter or an area, or measure the enhancing portions of the lesion because our therapy is absolutely ischemic. And so the lower level is more or less the advanced level, but all of it is just caliper-based manual measurements done by radiologists. So the limitations of those systems, even of the enhancement-based, are absolutely obvious. We are measuring this on a single slice. The selection of the slice is very dependent on the reader. It's very difficult to select the same slice on baseline and follow-up imaging, and it's a very non-reproducible technique to do. And plus, because of we're inducing such ischemic insult to those lesions, we have vastly heterogeneous tumor tissue, and we also have focal enhancement patterns on one slide that do not represent the entire tumor. And so this tumor assessment using manual caliper-based measurements is potentially imprecise. And so we added, together with Philips and our research, we added new 3D quantitative assessment techniques, the volumetric resist and the quantitative easel, which provides you a measure, a very scientific measure of the enhancing tumor volume measured in cubic centimeters. This is something that we've been working on and validating over the last 5 years, and it has become a product because it is very specific and provides you a very scientific value that no manual measurement can do. So we validated the system across different modalities. Here you see it validated for the MRI and for intraprocedural cone beam CT. We measured it across different users, and you see that the segmentation overlap is done semi-automatically, and it is actually fantastic because it's very, very user independent, and it's fast. Now, the next question that we asked ourselves really was, fine, we have a great tool, super, super great software, but does it actually represent this, what's going on in pathology? And this was the study that we published in Radiology, a seminal study, several followed after that. Does contrast-enhanced 3D quantitative imaging represent actual histopathology? And the answer here was clearly yes. If you look at the images, QEasel provides you a quantitative map of the tumor enhancement, and at the same time, if you look at pathology, you see that this is exactly the overlap. You see the viable tissue around the necrotic core after the embolization, and we could see in those people who got their tumors explanted that what we do in imaging absolutely represents pathology. The next question that we asked ourselves, can 3D quantitative imaging markers be used for response assessment? And for that, we really needed to go all the way and compare them with all the conventional techniques. And that we did again. We published that in Radiology, and we compared all the 1D, 2D, and 3D technologies as response markers for this particular local regional therapy. And what happened is that if you look at RESIST and you compare responders versus non-responders after this therapy, tumors don't really shrink that much, and so there is no separation in survival. M-RESIST, modified RESIST, is somewhat better. There is a separation of the curves, and you can see that the measurement of enhancement, even if done manually, still is better than the measurement of the whole anatomic size, but still not ideal. Now, if you use QEasel, not only do you have a significant separation of the survival when you measure your responders versus non-responders, you also have a very substantial separation of the expected time to progression and time to death. That means someone who is a responder according to QEasel really lives longer, and someone who is not can be early identified and treated very, very fast after that. So conclusions, non-3D assessment completely failed in our context, and the 3D response criteria were the only ones to be successful early, to provide early and clear identification of responders and non-responders, and to be also actually relevant for the survival prediction. Now, does QEasel work for HCC or only for HCC? If you look at primary liver cancer, we actually wanted to validate that in other biologies and colorectal mets and other diseases. And the liver really offers you a lot because the liver is the main metastatic organ of most GI tumors. And here we showed the same thing. We published it in European Radiology. We demonstrated that QEasel is also valuable and also of value in colorectal mets and with several other mets, with soft tissue sarcoma, renal cell carcinoma, uveal melanoma. And what happens in the liver technically is also widely applicable to a wide variety of other tumors. So the next level of QEasel, or 3D quantitative imaging at this point, is really to understand the tumor burden analysis. What is that? Can we standardize the way we report how much tumor is there in the liver? And we can, so we developed a concept of the enhancing tumor burden, which calculates the tumor volume within the liver, the enhancing tumor portions, the viable, and relates to the whole entire volume of the organ. The liver has a very, very important function. I'm not going to go deep into that, but the volume of the replaced liver is very important. That's why you cannot just look at the tumor, you need to look at the whole organ. And together with this tool, we're able to really quantify the enhancing viable tumor burden in the liver. And again, we were able to demonstrate that patients with a low enhancing tumor burden live significantly longer and substantially longer, look at this curve separation, than those who have a very high viable tumor burden. We also introduced that as a tool for tumor response for disease that you cannot segment lesion by lesion and tumor by tumor. And for example, for neuroendocrine metastases, published this in Radiology, demonstrating that this tool is actually widely applicable. Now, this is the source of pride and the cause for halftime in my talk to say we went from bench to bedside, and this is now a product that is widely available with Philips. The only limitation is that you need to have the Philips platform. It is not yet widely applicable to other platforms, but it does its job, and so far it is limited to the liver, but we can also look into the future where we apply it beyond. Now, what is going to be the day after tomorrow? And this is not yet a product, but I just wanted to outline a vision for you, a vision on machine learning and the value of artificial intelligence in liver imaging. So we're looking at fully automated tissue classification that will be created using machine learning techniques. We will also have tumor compartmentation and multiparametric tumor characterization. We will be able to separate those tumors in certain tissue subforms and really look into a sort of virtual biopsy and compare it with digital pathology. And ultimately, we will be able to create a molecular imaging system that will image the tumor microenvironment. And all that we ideally can integrate then into the interprocedural framework and then treat our patients with much, much more information than we had so far. Handling complex data. You see all machine learning all around this Congress this year. So what is actually a neural network? And it was introduced by the US Postal Services, not the most creative services in the world, but this was used for many, many years by them to really classify the digits that you put on the envelope. And if you look at those numbers, what are these digits? This is a 4 and a 2. And in essence, what they did is pattern recognition. And diagnostic radiology, let's be frank, is pattern recognition plus discussion on the findings and then a suggestion. So the pattern recognition part can be automated. Machine learning versus deep learning, this is a very important distinction that people must understand. The traditional machine learning requires the definition of certain features that the machine needs to learn, while the deep learning learns the relevant features all by itself and picks them up. But there is a huge but. For deep learning, it needs a lot of data. The amount must be really, really high. It's 10 by 6, so hundreds of thousands of data sets, and we don't have that yet. So it's going to be machine learning for now. But what are we going to do with that? We're going to use QEasel data and other quantitative imaging data, plug it into training sets and algorithms that learn certain features and learn to extract those features automatically. And we will then plug this information onto predicting data set, your clinical platform where you have your individual patient, and you will be able to get more information just based on the experience of the machine from learning from previous data. And we have a multiparametric approach. As you know, we increasingly, in liver cancer specifically, work with multiple modalities. We have the MRI, which provides you vascularity and information on viability. With diffusion imaging, you have information on cellularity and necrosis. With MR spectroscopy, some metabolites. And the future is going to be there, cell surface markers and immune system and new contrast agents for pH imaging. At the same time, CT also offers information on tissue density, flow dynamics. All that needs to be registered into one big framework, and what needs to be done is that we're then looking at signal intensity, and we can do two things. We can look at signal intensity and extract using a voxel-wise analysis and identification of 3D nosologic habitats. We can actually really do it right now. We can extract tissues. We can qualify tissue in the liver automatically without user interaction to viable tumor, for example, portal vein, parenchyma, and necrosis. And the same thing is true for signal distribution, not only intensity. We can use texture entropy analysis to really extract the distribution, the spatial arrangement of signal rather than this signal itself. And then we can group those voxels based on their properties and not based on their location. And what comes about is a probability map for tissue types. This is going to be your automated reading of liver cancer and the liver tissue. What happens then, you feed this map into a random forest learning algorithm, for example, a random forest, and then create an automated probability map that gives you a tumor burden, a response, and also qualifies your tissue as dead or viable. And ultimately, this will lead, with all the modalities that are being brought to the market right now, to an automated microenvironment mapping for liver cancer. Now, this is how the implementation into the clinical workflow works. Where is the clinical value? So far, we have the referring physician who sends the patient over to us. We do have the image acquisition because we suspect cancer. Potentially, we biopsy it or we diagnose it, and then we send the report back or do an intervention, which is local regional tumor therapy or systemic chemotherapy. We believe this is old-fashioned. The way radiology was practiced is old-fashioned. What's going to be happening now is going to be a background, additional decision support system where we use the images that we acquire even before the radiologist reads them. We do image post-processing and plug it into an algorithm that is based on machine learning, and then we'll get more quantitative imaging biomarkers that will be of help for interventional radiologists as well as diagnostic radiologists, and will provide better decision-making rather than replace jobs. And so the ultimate idea, the vision of all this in interventional oncology, is to have all this information readily available into the cone beam CT setting to map the vascular pathway using tools like AmboGuide, and then have a multimodality guided image-guided intervention that will be highly standardized, individualized, and provide a individualized personal assessment of therapy of the disease. The conclusion here for me is very straightforward. Number one, local regional therapy, and this is our playfield, they alter radiological gestalt and imaging characteristics of those tumors fundamentally. So the post-procedural imaging requires out-of-the-box thinking. You need to really have some very specific holistic approaches rather than simple caliper-based measurements. The age of software-assisted everyday solutions is already here, and the machine learning has begun, as you can see across all this Congress, and the clinical value will grow, improve, and maybe replace current workflow, but likely not the physicians. And so I would like at the end to really thank Philips for the opportunity to present our work of 5 years here, and also thank our partners, Dr. Lin, who is an on-site clinical scientist in our group, Dr. Schlachter, and all the other collaborators across the Yale Research Network that work with us and help us to create all that. With that, I thank you.
Thank you, Dr. Chapiro. And thank you all for attending. Dr. Chapiro, you had mentioned, thank you. You had mentioned that there's a lot of a future in machine learning algorithms as well, so I just wanted to remind everybody that Philips does have a presence in the machine learning forum way in the back if you want to understand where we're headed with these sort of algorithms, both on the portal and on Illumeo. And for those who are interested as well in learning a little bit more about QEasel and seeing how the COBE and LOBE application work, George is standing right there. You can raise your hand. He's our lead for the portal, and he can be able to take you down and have you experience some of this on your own to get some hands-on experience with how all this works out.